Hello, everyone. Our topic today is about fistulas in palliative setting. These are the objectives of our presentation today. Fistula, by definition, is an abnormal connection between two body cavities, or a body cavity and the skin. They can occur between the rectum and the vagina, or the intestine and the skin. They can be caused by inflammation inside the body that worsens to the point that they form a tunnel in the internal tissues. Fistulas are usually diagnosed through the use of a physical exam, a computed tomography, and if needed, other tests such as barium enema colonoscopy, sigmoidoscopy, upper endoscopy, or fistulogram. This is a schematic representation of a fistula. A hollow organ like a urinary bladder, intestines, etc. And this is the other side that could be the skin or another hollow structure like pancreatic duct, for example. And the fistula is this epithelialized connection between the two. A fistula is an abnormal communication between two internal organs, internal fistula, or between the skin and internal organ, external fistula. Fistulas can be classified also according to the amount of the output. Low output, less than 200 ml per hour. Moderate output, 200 to 500 ml per day. And high output, more than 500 ml per day. Fistulas may be single or multiple. In oncological patients, the most frequent causes of fistulas are related to cancer, local progression of the disease, and or local relapse, and or the treatments, surgery, radiotherapy, chemotherapy, anti-angiogenic biological therapies, local regional liver tumor ablation, photodynamics, endoscopy, and invasive diagnostic procedures. Causes of fistula. Causes related to the treatments, such as surgery, chemotherapy, radiation, photodynamics, endoscopy, and other invasive diagnostic procedures. Causes related to the cancer itself, tumoral local progression, local regional relapse of the disease. Mixed causes correlated to treatments and to cancer. Frequent complications of fistulas: infection, hydroelectrolytic losses, malnutrition, skin losses, hemorrhage, delay in oncological treatments, psychological problems. Sepsis is the most frequent cause of death in patients with fistulas. Nutritional status as well as condition of impaired tissue vascularity may be predisposing factors. General management of fistulas. Conservative measures such as skin care and local disinfection, pouching of secretions such as the ones in gastric or pancreatic fistulas, control of odor, delicate fistula areas, and use of antibiotics against anaerobic bacteria, a drug like metronidazole, control of local itching and pain, control of infections, specific antibiotic treatment, care and use of corticosteroids, radiotherapy, and chemotherapy. Control of nutrition and electrolytes, particularly in high output fistulas, and eventual TPN, and anti-secretory treatments such as scopolamine and octreotide. Treatment of site-related symptoms such as antiemetics, antispastic, antihemorrhagic, anti-secretory, use of vasopressin for urinary incontinence, use of urinary catheters. Control of psychological condition such as distortion of body image, isolation, and social discomfort. Non-conservative management, such as surgical resection of fistula, surgical repair with corrective procedures, or with myocutaneous flaps, colonic and urinary diversion. Endoscopic treatments with metallic stents. Esophageal fistulas. Esophageal fistulas may be classified as oesophago-respiratory, particularly esophagotracheitis, and esophago-cardiovascular. As far as the first ones concerned, most of them are due to esophageal carcinoma, 75%, and lung cancer in 16%. The patient's symptoms may be dysphagia, coughing, aspiration, suffocation, and fever. Whenever the patient's clinical condition allows it, surgery may be performed with an eventual gastrostomy and/or jejunostomy and the use of metallic stents and/or palliative radiotherapy. Regarding self-expandable metallic stent, stricture of the upper esophagus and shorter stent patency are independent predictors of initial clinical failure. Moreover, initial clinical failure is an independent predictor of shorter survival. This is the anatomy of the esophagus and the trachea, as you see, and then you have the aorta in front. That's why the esophageal fistulas connects either with the trachea or the cardiovascular system. Chemotherapy is indicated particularly in the presence of lymphomas. Stents are used also for palliation of other symptoms or issues, such as dysphagia. In these cases, plastic stent, conventional stent, and fully covered self-expandable metallic stents were better treatments in terms of lower risk of fistula formation. From a prognostic point of view, patients with esophago-respiratory fistula are a higher risk of developing lung abscesses, empyema, and pneumonia. Esophagocardiovascular fistulas are very rare in cancer patients and also can include the aortoesophageal fistula, which is mainly caused by the rupture of the thoracic aneurysm in the esophagus and the esophagocardiac fistula. This is a fistula here in the esophagus, as you can see. Gastric and duodenal fistulas. More than 90% of gastric and duodenal fistulas are a consequence of surgery in these areas. Postoperative fistulas are frequently due to an anastomotic leak and abscess formation. Cancers of the transverse colon, stomach, duodenum are more prone to fistulization. Other rare causes are lymphomas and the placing of pumps for chemotherapy infusion in the gastroduodenal artery. While external fistulas are easily diagnosed, internal fistulas that can cause diarrhea and nutritional deficit are less detectable. Generally, internal fistulas diagnosis occurs between the 5th and 10th postoperative day. Main fistulas-related complications are sepsis, abdominal abscess, wound infection, pneumonia, and intra-abdominal bleeding. Most postoperative gastrointestinal fistulas heal spontaneously within 4 to 5 weeks. Factors associated with poor healing or delayed healing include multiple fistulas tracts, malnutrition, acute infection or sepsis, level of serum transferrin, unfavorable if it's less than 200, cancer progression, and previous radiotherapy carried out in the involved areas. Treatment of gastric and duodenal fistulas may be medical, endoscopic, or surgical. Nutritional support and treatment of infection are essential in the management of postoperative fistula. So, just to wrap this up, gastric and duodenal fistulas are usually surgical, postoperative, uh, you know, uh, in origin, compared to the esophageal fistulas, which usually related to the cancer itself. Okay, especially the esophageal, respiratory fistulas, which are the commonest types of fistulas with the esophagus. The treatment is either conservative or non-conservative in both cases, surgical or non-surgical. Okay, uh, with the conservative, the most important thing is to focus on the nutritional and support and electrolyte support, treating of infection. And then, as far as non-conservative, you can do, put stents, or do surgical intervention to remove the fistula and others. Gastric and duodenal fistulas, conservative or endoscopic percutaneous treatment is the first choice. However, if the patient a clinical condition worsens, surgery becomes mandatory, and duodenostomy appears to be the most effective surgical procedure. Endoscopically, some authorities have reported obliteration of the fistula tract with adhesive fibrin tissue. For patients with persistent fistulas and a good performance status, three different surgical approaches are described: exclusion, resection, and closure of the leak. The exclusion of the fistula is not a treatment of choice and is reserved in very ill patients. This procedure is carried out with the resection of the disease segment and exteriorization of the end parts. In this way, an uncontrolled anastomotic leak is converted to a controlled external fistula. However, the procedure of choice is usually the resection of anastomotic leak with the formation of new anastomosis. Major contraindications to this procedure are ischemia or tension on the anastomosis. If the resection of the anastomotic leak could not be formed, the closure of the leak with a serosal patch or Roux-en-Y anastomosis is the preferred surgical alternative. Okay, we'll get into the pancreatic fistulas. Pancreatic fistulas are more frequently external and are usually complications due to the upper abdominal invasive procedures on the pancreas or surrounding areas, and it occurs in 6 to 25% of pancreatoduodenectomies. Fistulas are more frequent during the first postoperative week and present with a high level of serum amylase. So, I mean, as you see, each fistula has its own characteristic. For example, pancreatic fistulas are external and usually complication to upper abdominal invasive procedures. Okay, so you have to kind of make distinction between, but general rules apply as far as conservative or non-conservative measures. With the conservative, focus on the nutritional support and electrolyte imbalance and infection, and also doing endoscopic procedures, putting stents and stuff like that. And as far as non-conservative, will include surgeries. This is basically the bottom line of all fistulas. So try to apply these rules in every case. So anyway, they are usually diagnosed by radiological examination, such as fistulography and CT scan, ultrasonography, endoscopic, retrograde cholangiopancreatography. Interleukin 6 levels in the 96 postoperative hours seem to be associated with the development of pancreatic fistula. Postoperative external fistulas heal spontaneously in 80% of cases, with conservative treatment incorporating skin care, drainage, collection of pancreatic secretion, control of infection, and parenteral nutrition. To reduce the pancreatic secretion, we use octreotide in doses of 50 to 200 mics per 3 times a day, and has been used in conservative treatment to reduce GI secretion. So octreotide has a role here to reduce the amount of secretions from pancreatic fistula. Again, go back to the general rules of general measures, conservative versus non-conservative. And some of the conservative measures is giving, octreotide and anticholinergics to reduce the secretions in high output fistulas. Okay, so I mean, it totally makes sense. What we're talking about so far. Many authors suggest the use of subcutaneous injection of octreotide in doses of 50 to 200 mic 3 times a day, according to the output. However, some authors have expressed some concern about the use of octreotide in the treatment of pancreatic fistula. This is just to show you putting stents. Pancreatic fistulas surgical approaches are reserved for situations of conservative management failure in patients with good performance status and a favorable tumor anatomy. The placement of endoscopic stent has proved effective in certain studies, but longer follow-up is necessary to evaluate possible long-term complications. The randomized trials have demonstrated the role of external stent drainage to reduce post-operative pancreatic fistula after pancreaticojejunostomy. Post-operative pancreatic fistulas-related mortality has remained at approximately 1% over the past 25 years. Only externally draining and transanastomotic stents were able to decrease the post-operative pancreatic fistula-related mortality rates. So we'll get into the small bowel fistulas. Intestinal fistulas are, again, internal, external, mixed. The most common are external. Most of them are a consequence, again, of postoperative complications following surgery on GI cancers, with diastasis of the anastomotic wounds and damage to the bowel and vascularization. The severity of the anterior cutaneous fistula depends on the site, amount of secretions. For example, large volume secretion and small bowel fistulas can be associated with severe fluid and electrolyte abnormalities and malabsorption. A rare presentation of anterior cutaneous fistulas may be subcutaneous emphysema. Intercutaneous fistulas may heal spontaneously with adequate supportive therapy, including total parenteral nutrition, prevention, and treatment of infective complications in 70% of cases. Several studies supported the use of somatostatin analogs to reduce the secretion volume. But a recent meta-analysis suggests that somatostatin is octreotide, by the way, it's the same, could be better than analogs in relation to number of fistulas close to time to closure. Colonic fistulas, although considered uncommon, can also be classified as external or colocutaneous or internal, such as colovesical, colovaginal, coloenteric. The most evident sign of colocutaneous fistulas is the passage of air and feces through the incision in the abdominal wall following surgery. Other signs are symptoms of sepsis and fever, tachycardia, leukocytosis, and pain due to abscess with local peritonitis. Patients with internal fistula complain of various symptoms according to the viscera involved. Patients with colovesical fistulas frequently complain of cystitis, high fever, shivering, and sweating, and if the fistula tract is wide, pneumaturia and fecaluria. Patients with colovaginal fistulas suffer from an increase in the vaginal secretion, sometimes associated with passage of feces. Patients with coloenteric fistulas suffer from abdominal pain and abundant diarrhea. Diagnosis of colovesical fistula is obtained by a means of cystoscopy or colovaginal fistulas by means of a fistulogram or vaginogram. For coloenteric fistula by an abdominal CT scan with contrast. Colonic fistula, the colocutaneous fistulas may be conservatively treated even if the rate of the healing is lower than enteric ones, particularly the presence of malignancy or distal occlusion. Some patients may require surgical bowel diversion. In the presence of malignancy, a partial cystectomy performed together with the sigmoid colon is indicated for colovesical fistulas. Radiotherapy-induced fistulas may be complex and often involve more than one organ, for example, the colon or rectum respectively with the bladder, the vagina, small bowel, and skin. These fistulas are more difficult to treat because of the low rate of spontaneous healing and high rate of relapse. It is possible to treat coloenteric fistulas with stents. Types of colonic fistulas: colovesical, colovaginal, coloenteric, colonic, colocutaneous. Colovesical fistula. And then you have also anal fistulas, which could be transsphincteric, intersphincteric, extrasphincteric, and suprasphincteric. With the commonest one is intersphincteric. And next to it is the transsphincteric. And this is the fibrin sealant that we talked about, which is a mixture of fibrinogen, thrombin, and calcium ions, forms a fibrin clot, avoids sphincter compromise. So this is sometimes we use to seal these fistulas. Head and neck fistulas. As regards head and neck cancer patients, the most frequent fistulas are pharyngocutaneous, and they are the most common complication resulting from total laryngectomy. So as you can see, most of the fistulas are related to surgery, okay? Except maybe the esophageal carcinoma so far is related to the cancer itself. It was observed that 12 to 16% of patients undergoing laryngectomy develop fistulas 11 to 14 days after surgery. Although spontaneous fistula closure occurs in two-thirds of these cases, about 20% of these patients have to undergo surgery to direct suture of the pharyngeal mucosa or reparative surgery by means of deltopectoral flap or pectoralis major myocutaneous flap. Negative prognostic factors give rise to the fistula can be a hemoglobin level lower than 12.5, concomitant heart pathology, extension of surgery, surgeons experience tumor size and the use of catgut. A randomized study demonstrated the efficacy of arginine supplemented enteral nutrition in this group. I mean, when you look at the picture here, the big picture, I mean, all of these fistulas, they have something in common here. Okay, what is the origin of or the cause? This is the first question you want to ask yourself. Then you want to classify this fistula. Is it internal or external? Is it high output or low output fistula? Then the management is basically conservative and non-conservative. That's the bottom line of this whole presentation here. We'll continue the head and neck fistulas. Previous radiotherapy to the head and neck increased the risk of developing fistula by 10 to 12%. In some group of patients treated with radiotherapy, the percentage of fistulization increases up to 30% after total laryngectomy with prolonged hospitalization. Some authors suggest using growth factors with the aim of preventing infection and sepsis. The concomitant use of oxygen therapy and radiotherapy favors nail vascularization and prevents fistulas from occurring. Another relatively frequent group of fistulas are the esophageal ones, already described in the paragraph esophageal fistula. We described this at the beginning of our presentation. Bronchopleural fistulas is a communication between the pleural space and bronchial tree. Bronchopleural fistulas are often correlated to pneumonectomy. Again, post-operative. Remember this, post-operative. Pneumonectomy in treating lung cancer. Incidence is about 8 to 10%. What are the risk factors? Again, the same token for development of fistulas, post-operative infection, pneumonectomy, the presence of subcarinal metastatic lymph nodes, and preoperative radiotherapy and diabetes. So it makes a lot of sense. Okay, most of the risk factors are related to infection, related to malnutrition, related to reduced immunity, surgical intervention, radiation therapy. Moreover, low post-operative serum level of albumin can serve as a significant risk factor for post-operative bronchopleural fistulas in patients undergoing pulmonary resections. From a pathophysiological viewpoint, it is difficult to preserve the bronchial arteries in the dissection of metastatic subcarinal lymph nodes, which adhere to the bronchial tree. The bronchial artery's ligature or the protrusion of the bronchial stump in the pleura reduces the blood flow to very low levels, thus favoring fistula development. The most common signs and symptoms are air in the pleural cavity, dyspnea, and front chest pain. Diagnosis is usually carried out by bronchoscopy. Although recently, scintigraphic techniques with xenon 133 and technetium-99 have given good results. Surgery is the first choice of treatment whenever possible. However, in the case of fistulas less than 3 millimeter successful results have been found by means of a reparative endoscopy. A thorough follow-up in the first 3 months after pneumonectomy is indicated as preventive measures. Genitourinary fistulas. As you see here, a fistula opening is seen in the bladder here. Genitourinary fistulas has an incidence of 2% in cancer patients. The most frequent causes are surgery, hysterectomy, prostatectomy, rectal resections, pelvic evisceration, radiotherapy, and pelvic organs, and locoregional relapses. Signs and symptoms are characterized by urinary incontinence, pain, and itching at the fistula site, pneumaturia, sometimes fecaluria, GI disorders, hemorrhage, often present with the psychological distress. For diagnostic aims, the following are often used: a CAT scan, MNR, cystoscopy, a barium enema, charculuria. As far as anatomical site is concerned, the most frequent fistula is the group of patients with rectovaginal, enterovesical, vesicovaginal, uterovaginal, urethro-cutaneous, and rectourethral. And then you have rarer types. The rectovaginal and enterovesical fistulas are often the consequence of radiotherapy in the pelvis, with necrosis of the vaginal and rectal walls or hysterectomies. So, carcinomas of rectum, uterine cervix, and vagina are the most risk of fistulization due to the site and necessary treatments. So, genitourinary fistulas are often related to radiotherapy, not surgery, and usually related to certain types of cancer, such as the rectum, uterine cervix, vagina, and so forth. When the fistula is in the lower part of the rectum, fecal incontinence due to involvement of anal sphincter may be present. Profuse hemorrhages can be controlled by embolization. Vesicovaginal fistulas are often the outcome of hysterectomies, and the two orifices are 1 centimeter above the trigone of the bladder and anterior wall of the vagina. These fistulas heal using a catheter from 12 to 20 days with a closed drainage to prevent infection. Uterovaginal fistulas are often a result of rectal or radical hysterectomy. So another type of fistula is here, the uterovaginal, is a result of surgery, radical hysterectomy, via laparotomy. The risk of renal damage should always be taken into consideration, and the areas most at risk of fistulization are common iliac artery, uterine artery, and sacrouterine ligament. The treatment of fistulas in these areas is the use of urethral catheter or FINI, when possible, or eventually a ureterocystostomy may be indicated. Urethro-cutaneous fistulas may be frequently concern the prostatic urethra as compared to bulbar urethra. The urethro-cutaneous fistulas is the result of perineal prostatectomy, and there is almost always a concomitant prostatic abscess. The cutaneous orifice is usually central and in preanal area. The urethral orifice is located above the urogenital diaphragm and may reach the bladder. The ureterorectal fistulas are often associated with carcinoma of the rectum, prostate, bladder, and concomitant abscess. The rectal orifice is suprasphincteric, concealed behind the mucosal fold or in the Morgagni cyst. The urethral orifice is situated in prostatic urethra. The vasicocutaneous fistulas are rarer, are often correlated to the lesions of the bladder fundus on the laparotomic wounds. Vesicocolic fistulas. Okay, we're going to end our presentation with key learning points. In cancer patients, fistulas are complications to be held in consideration due to delays that can be caused by the treatment of cancer, as well as worsening of the patient's clinical and psychological conditions. Prior to planning conservative treatment versus invasive one, it is mandatory to assess the patient's chances of survival as well as his quality or her quality of life. Considerable effort should be made by caregivers in order to manage all the different symptoms related to the complication in cancer patients. I want to just add my own view about this presentation. I mean, it seems like a kind of a little bit complicated presentation, but if you really think about it and just take the main lessons from this presentation, which is basically fistulas are a common complication from cancer or the cancer treatment, okay, whether surgical or radiation. And the symptoms produced by these fistulas could affect the quality of life. All right. Also, fistulas can cause complications such as sepsis. It can cause nutritional, deficits, especially high output, fistulas. And the management is either conservative, which are basically, there are general rules treating the infection, boosting the nutrition, dressing, and all that stuff, and then using endoscopic, procedures to, to get rid of these fistulas. All of these are under conservative measures. And if these conservative measures are not adequate, then we go into invasive procedure, using, consulting our surgical colleagues, for the surgery. This presentation is basically is raising the awareness of the importance of fistulas in our, field, in the palliative care field, and you need to communicate with your colleagues, whether gastroenterologist or urologist or the surgeon, general surgery, to kind of come out with a good plan for this patient, which also you'll be part of it because you're the one taking care of the patient, and uh, you're able to see the patient performance here, whether this patient would benefit from surgery or not, and whether this fistula is affecting his quality of life or not. Thank you.